Welcome to ICS Live today. I'm Kari Tikkinen, urologist from Helsinki University Hospital and University of Helsinki, Finland. Before I introduce Philip, please make sure you post any questions you have for us in the comment section below, and we will get back to them at the end. I'm very sure that we will have a great lecture today on neuromodulation by Philip van Kerrebroeck. Philip was born in Leuven, Belgium, and completed his medical school also in Belgium. He completed his training in surgery and urology both in Belgium and the Netherlands, and got his board certification as urologist in 1984. He was very long-acting professor of urology in Maastricht, Netherlands until last fall. Philip really is a true world leader and expert in functional urology, including the treatment of neurogenic bladder dysfunction. His research interests include development of various new therapies in neurourology, such as neuromodulation for lower urinary tract dysfunction. Philip has also been very active over the years in the International Continence Society, and it is very hard to imagine any speaker who could be better today for the topic. Again, ladies and gentlemen, remember, please make sure you post any questions you have for us in the comment section below, and we will get back to them at the end. Philip, please, online floor is yours.
Thank you, Kari, for the kind introduction. I also would like to thank the ICS for this opportunity to present today on neuromodulation for the lower urinary tract dysfunction. Dear colleagues, good afternoon, for perhaps some good morning, and for others good evening or even good night. Welcome to this ICS Live session, where we'll discuss some current challenges in neuromodulation for lower urinary tract dysfunction. The reason why I choose this topic is because in recent years, there has been a lot of developments that pose some clinical problems, and therefore I think it is the moment to discuss these challenges and to see how this can impact on our daily practice. Here you see my disclosures. As you can see, I have been and I am working with a lot of companies developing new treatment forms, especially in the field of neuromodulation. But in the lecture, I will try to give as broad an overview as possible and try to create no bias in that respect. Why neuromodulation? Well, we still are facing the fact that many patients with lower urinary tract dysfunction, this can be symptoms of overactive bladder or problems of functional retention, do not find a solution with conservative or minimal invasive therapy, as for example, pharmacotherapy. So therefore, that leaves us after maximum conservative treatment with between 40 to 60% of patients with severe problems that have persisting symptoms and necessitate different solutions. Now, as we've been discussing in the past years, in case of a patient with symptoms of overactive bladder, there are only two interesting modalities, which is botulinum toxin or neuromodulation. Today, we will not discuss the differences, the advantages or the disadvantages of botulinum toxin versus neuromodulation, but focus on neuromodulation with the pros and cons of that therapy. In my view, one of the major advantages of neuromodulation is that it has the potential of curing or at least improving all the symptoms related to the lower urinary tract. So it is a global approach, not attacking only one element, but as well storage problems, avoiding problems. And as we know, quite often, even in patients with symptoms of overactive bladder, there is not only a storage problem, there's also avoiding problem that will be attacked by neuromodulation. Furthermore, we know that a significant number of patients have concomitant other symptoms with lower urinary tract symptoms, as for example, constipation or even fecal incontinence. And also these symptoms can be addressed with neuromodulation. Of course, when we approach such a therapy, and definitely when talking neuromodulation and we talk on an implant, we should be aware that any implantation can cause some side effects. And hence, we should aim at having a minimum of side effects. And The new therapeutic modalities that we will discuss in this lecture clearly are looking for minimizing the side effects and at the same time eventually increasing the clinical efficacy. So as such, as with any therapy, we have to look for the balance between efficacy and safety to come to an optimal balance that we call clinical efficacy in order to have better compliance with the patients and a better persistence of the therapy. Now, especially at the side of safety, there has been a lot of criticism in terms of neuromodulation because of battery replacement, technical problems, and hence industry has been very helpful in developing new technical developments that ameliorate the quality of the therapy. To set the scene, let's discuss the actual situation till quite recently. In fact, there were only 2 treatment modalities that were commercially available and were approved as well by European authorities as by American authorities, the FDA. The first was the sacral nerve stimulation with the InterStim II system, as it has been developed over the years by Medtronic. That is a system that is already in use in the 90s of last century. At this moment, more than 300,000 patients have been implanted worldwide with this system. Although we have to confess that in recent years, of the patients implanted with this system, more patients with fecal incontinence have been treated than patients with symptoms of overactive bladder or functional urinary retention. The InterStim II system is what we call a recharge-free system. That means it consists of an electrode connected to a battery with a permanent output. Okay. So this is the slide that I'm discussing now. It's correct? Neuromodulation. Okay, we'll do that. I will go out. I don't know what I did wrong.
Hello, I'm sorry to say, but I was dropped out. I'm now back. Sure, happy to do. I'm sorry that I was also dropped out, but I'm now back on track and I will try my best.
Okay, so we can go. Next slide, please, Kari. Yeah, so I was discussing this slide indicating that sacral nerve with the InterStim II has been implanted in more than 300,000 patients. Of it, in recent years, the majority, however, were patients with fecal incontinence. There has been some reluctance to implant this system because of the morbidity of this system, the technical problems that were encountered, and also, of course, the cost. The InterStim II system is what we call a recharge-free system. That means that there is an implanted battery that does not have to be recharged and has a permanent electric output. The advantage of the InterStim system is that, as I said before, has been implanted since the 90s and has shown long-term efficacy that is persistent over years. The second system that has been evaluated and is clinically recognized and has been recognized also by European and American authorities is the so-called percutaneous tibial nerve stimulation, where a needle is placed in the neighborhood of the tibial nerve at the ankle of the patient, and then the stimulation sessions are implanted. So there is a form of intermittent temporary stimulation that attenuates the symptoms of overactive bladder, and then will have a prolonged effect for 1 week to 2 weeks, where then a session has to be repeated. Next slide, please. The disadvantages of the InterStim II system, however, is that it is only approved for MRI head scans. And that means that patients that need a body MRI scan cannot be implanted, or when they're implanted, eventually even have to be removed of their implant. Now, when we see an increasing request for patients to have an MRI scan, globally at the moment, about 50% of the patients that have been implanted will need an MRI sooner or later in their life, which creates a problem. And indeed, some studies have shown that about 23% of the explantations are happening because of an MRI indication. The second problem with the InterStim II system is that the actual battery, the InterStim II, is only delivering an output, electric output, for 5 to 7 years, and then a battery replacement is necessary, which necessitates a surgical intervention that in the majority of patients can be performed under local anesthesia, but in some patients may request general anesthesia. Also, any intervention bears a risk of infection and therefore is a negative point with such a system. Furthermore, the InterStim II system is quite a bulky battery that has a volume of about 14 cubic centimeters, and definitely in slim patients can create a problem. The disadvantages of the percutaneous tibial nerve stimulation are the repeated needle puncture, as I said, that makes that some patients are fed up with having this repeat needle punctures, and also the repeated punctures necessitate a laborious workload for nurses and doctors, and therefore, after a lot of enthusiasm, percutaneous tibial nerve stimulation is not that popular anymore in many centers. Next slide, please. So, when we have new technology, what are we talking about? Of course, one of the first achievements, and I will illustrate that in a few moments, is that we have now systems that are able to be put in an MRI scanner, and hence there is full body MRI safety. That means a patient that has been implanted with these systems still can be put in an MRI scanner. That means, in theory, that more patients can be treated and that the eventual necessity or the potential necessity of an MRI scan is not a contraindication for implantation anymore. And I'm sure that in patients implanted, this will create less explants because patients that have an implant can have an MRI. The second major development was the fact that rechargeable batteries have been developed. That means that there is an implanted battery, but that from an outside source has to be recharged. This type of batteries, and I will illustrate that in a few moments, have a longer longevity because they can be recharged and not dependent on the inherent amount of energy in the battery, and hence there will be less frequent need for battery replacement. An advantage also of the rechargeable batteries, and that's a third positive element of recent development, is that these rechargeable batteries are smaller than the non-rechargeable batteries or the recharge-free batteries, and hence create a greater patient comfort. Next slide, please. Next slide. Yeah. So what is available on the market, as we say? The first rechargeable system that came on the market, now in Europe already 1.5 years ago, is a so-called r-SNM system developed by Axonics, a company from Irvine in California, USA. At the right side, you can see the Axonics battery. That is a rechargeable battery, and you can see the size compared to a $250 piece. So it is a small battery with only 5.5 cubic centimeters. It is safe for the MRI, and as such is a system that fulfills these three advantages as I indicated before. A second system that came on the market in the beginning of this year is the Interstim Micro neurostimulator and sure scan, developed by Medtronic in Minneapolis, USA. That is also a rechargeable battery that clearly is smaller than the InterStim II. And for comparison, you see the micro neurostimulator and the InterStim II in terms of size. And the micro neurostimulator is even smaller than the Axonics battery. Also, this InterStim Micro neurostimulator is full body MRI safe. Next slide. Next. So the advantages of the smaller batteries are of course that there is potential more comfort for the patient, that there is less operative trauma in implanting them, and as such, we can see this as advantages. However, these advantages also can turn into a potential disadvantages. For example, as the batteries are smaller, it can be more difficult to position them well in obese patients. Because when we implant these batteries too deep under the subcutaneous layer, recharging may be difficult. And we have to realize that about 40% of the population that are candidates for neuromodulation are rather obese and hence can create a surgical problem. Also, we have the experience that batteries in definitely more obese patients create an instability. That means that the battery can turn around, and the smaller the battery, the higher the risk of this so-called twiddler's phenomenon, where the battery starts to turn around on its own axis and even can create disconnection of the lead or fracture of the lead. Also, as the battery is smaller size, some patients can have difficulties in finding it, and this can create a problem with recharging. Next slide. So what are the biggest advantages further for rechargeable batteries? Well, the major advantage is that so far as we know, battery life in rechargeable batteries is up to 15 years. That means that there is less replacements needed and that the maximum time would be minimum 50 years before replacement is necessary. Again, these advantages have to be matched against some disadvantages, which is a patient compliance is needed because patients need to recharge the battery at regular intervals. So that needs a certain cognitive capability and manual dexterity. And patients can have problem with recharging the battery. Once the battery is out of power, there will be no neuromodulation and symptoms can reoccur. Also, patients need to think on this repeated recharging because otherwise they will lose the current and will lose the neuromodulation effect. Next slide. Another advantage of the recharge-free battery is the stable position in obese patients. As I explained, rechargeable batteries can move in an obese patient. The recharge-free batteries are more stable because of their volume. Also, if these recharge-free batteries have to be reprogrammed, there is an easy contact because they're easy to find. And there is no patient interaction with the battery needed because no recharging is necessary, and hence cognition and dexterity in these patients is not essential because the necessary programming can be done by a healthcare giver. Another advantage that we saw from a psychological point of view is that patients that have a recharge-free battery do not have this repeated perception of urinary problem, because that is quoted by some of the patients that have a rechargeable battery, that every time they have to recharge, they consciously have to think on the fact that they have a problem that they have to take advantage of. So the disadvantages of a recharge-free battery, of course, is the short battery life, as I indicated, that limits the battery life to 5 to 7 years. However, I have to indicate that in recent years, we were able to have a standard implant technique, which better positioning of the lead in the neighborhood of the nerve, and hence lower impedance and less current is necessary for the neuromodulation, hence enlarging the battery life. And in many patients now we see, even with an InterStim II battery, a battery life up to 8, 9, or even 10 years. Of course, in slim patients, the volume of this recharge-free battery can be a problem. Next slide. So that brings us then to the huge discussion. If we see a patient with persistent symptoms of overactive bladder that is a potential candidate for neuromodulation and agrees to be implanted, we have to make a choice between a rechargeable or a recharge-free battery. So what will be the indication for these batteries? Well, rechargeable batteries will need technology-savvy patients, compliant patients, motivated patients. It would be optimal for patients in need for high energy stimulation, also for slim patients, patients with a history of pain because they have a less volume battery implanted, and patients that eventually are prone to infection because there you want to minimize the number of battery replacement. I see that I make a mistake in the title of this slide because it should be indications for small rechargeable batteries. And there definitely we need this type of patients. So this is a mistake on my slide. I'm sorry for that. Next slide. So again, the same mistake here. This is what I see as patient assessment for candidates for a rechargeable battery. We have to take into account different factors, demographic factors. For example, the age in elderly patients, the regular recharging of the battery can pose a problem. Also, if in view of age, there is some cognitive impairment, patients may forget to recharge, and this can create a problem. There can be a gender issue. Perhaps some genders that are in a specific situation do not like to have this permanent necessity of recharging a battery. Also, education may be a factor in that respect. And also the fact that, yes or no, caregivers are in the neighborhood, because if patients have questions, they will need to have a team where they can be approached. Also, psychosocial elements are important. The motivation of a patient to recharge the battery. And in our experience with the Axonics system, this is half an hour once every 2 weeks. It needs still motivation, and it needs a certain attitude of taking care of your own body. So also health literacy and medical compliance is important. And hence, when we assess patients, we have to have a careful look at their medical history. We also have to take into account physical difficulties. For example, hand function of patients may be a problem. They have to have the ability to bring in an external equipment over the battery, keep it there for half an hour, and so a certain hand function is necessary. As I said before, a certain degree of cognition is essential because forgetfulness will make that patients forget to recharge the battery, and they will run out of power, and they will not have any neuromodulation effect anymore, which also could be a trouble for the caregiver because these patients then tend to call the doctor or the nurse to ask what is going on. Patients will have to come to the hospital to check what is going on, and so on. So it can create a logistic nightmare. Also, patients have to be ready to accept the complexity of maintenance. For example, they need a spot to recharge the external equipment that will allow them recharging the battery. So they have to have this capacity at home or in the neighborhood. We also should see the potential side effect of recharging, which can be that can sometimes be difficult to find the battery. The distance is too large, so there is no good recharging of the battery, and that also can create a problem. We also have to take into account the lifestyle of patients. For example, patients that are frequently traveling may have difficulties in recharging because they will have to find a spot where their connector connects well. Also, they may not forget their external equipment for recharging. And also, finally, there can be a cost issue because we know by experience that patients tend to break down their external equipment. They may lose it, it may be stolen, and so on. So costs may be involved, and that depends also on the healthcare system. So all these factors will be important in assessing patients that are potential candidates for these small rechargeable batteries. Next slide, Kari. So how to choose when we have a patient, how to choose between rechargeable versus recharge-free systems for sacral nerve modulation. I think we have to discuss the advantage and the disadvantages of each of these systems as we discussed it before. So we have to, from our medical side, have some selection parameters and address the different items, but we also have to address patient expectations. For example, we have to make an estimate of the motivation of the patient and we have to evaluate that. So we have to come to a shared decision-making process. I think as doctors, we cannot impose one system or another on the patient and have to discuss all the disadvantages and advantages. So an idea could be to have a candidate patient be in contact with an implanted patient already. With the recharge-free systems that we had before, this was something we did because patient organizations are very helpful in that respect, and new candidates can be in contact with patients that have experience with the system, that have been implanted, and the same could be true for patients that have been implanted with a recharge-free system or patients with a rechargeable system or both, and then patients can be more informed for their final decision. Next slide, please. So that are the systems as they are available nowadays. Now we come to a little look at the future, which will of course bring even more challenges to us. Indeed, a couple of experimental therapies or equipment, I should say, have been explored in recent years. The first system is the so-called AEL Levy system, developed by Nospera Medical Incorporation in San Jose. And you can see a picture of the system compared to a US penny. It's a miniature implanted stimulator at the left side, incorporated with the electrode, as you can see to the right side of the picture, with 4 contact points. So this is, again, a passive implant. That means that stimulation or energy has to come from an external wireless midfield powering unit that has to be brought over the stimulator part of this system and has to be there for the time necessary for stimulation. So there is, in this situation, no implanted pulse generator, and an external equipment has to deliver the energy and transmit it through this receiver to the electrode. You clearly can see the advantages and the disadvantages of such a system. A major advantage is that there is no battery, hence less material implanted. A big advantage or potential disadvantage could be that the patient needs an external equipment for the time that stimulation is necessary. Again, this is a research going on. This is not clinically available, and clinical research has to go on before this will come potentially on the market. Next slide. We discussed in the previous part of the presentation mainly systems for sacral nerve neuromodulation. However, as I said in my introduction, there are 2 different ways of approaching neuromodulation for the lower urinary tract. That is making use of the sacral nerve by sacral approach, or making use of the tibial nerve by approaching the tibial nerve at the ankle. For the tibial nerve, so far, there was only the percutaneous puncture, where a needle is brought in the neighborhood of the tibial nerve and with an external stimulation. In recent years, several companies have developed systems for permanent implantation in order to deliver tibial nerve stimulation. The first that has been developed and has been submitted to extensive clinical research is the Renova InterStim system, developed by the Blue Wind Medical Company in Herzliya in Israel. You can see the implant to the right upper side. So it is about 3 centimeter large electrode embedded in silicone with 4 little holes in the silicone in order to fix it to the fascia overlaying the tibial nerve. So again, this is a leadless implant that is brought in with an open procedure. So an incision of about 2 to 2.5 centimeters is made over the sacral nerve. This electrode is brought in, fixed with 4 stitches to the fascia overlaying the tibial nerve, and then external stimulation can be applied. Again, as we know from percutaneous tibial nerve stimulation, we see that a stimulation session once per week or once every 2 weeks is enough in order to have permanent neuromodulation effect. And indeed, I was personally involved in clinical research with this Renova system, and the majority of patients that we implanted had good clinical efficacy with a stimulation session of half an hour every 2 weeks, and had persistent results up to 1.5 years. Can you go to the previous slide, Kari? Let's move. Yeah. So a second system that has been developed is a so-called e-coin system. And again, you see it to the right side. It looks like a coin and is developed by Valencia Technology in California. Again, it is brought in with an open procedure, is positioned in the space above the tibial nerve, and is positioned there. And as in the previous system, is then stimulated from the outside. A third system for permanent tibial nerve stimulation or blunted tibial nerve stimulation is a so-called stim router that has been developed by Bioness company in California. To the right downside, you see the electrode, which is kind of a lead that is put in at the same level at the tibial nerve with an antegrade percutaneous implantation technique. That means from up to down, the electrode is brought in with specific equipment. A fourth system for implantation for tibial nerve stimulation is a so-called Protect PNS system that is developed and researched by a company called Micron, and some of you may know the company by her previous name, which was StimGuard. The same principle. It's an electrode lead that is implanted in the neighborhood of the tibial nerve, is prone to external stimulation after implantation, and this system, the Protect system, is implanted by a retrograde technique, as you can see on the right side of the picture down. So that means that this electrode is brought in with a puncture and brought in from down to up. Next slide. So what is the future of neuromodulation? I would say the clinical future, because part of our future has already been developed. There are several technical innovations that are major step forwards. I think the availability of smaller batteries is definitely a positive development. The fact to have rechargeable batteries is an extra argument for some patients to be prone for neuromodulation implantation. In my view, one of the major developments that really will make a significant difference in our clinical practice is the fact that the new implants are MRI safe. Because in my personal experience, this was one of the major reasons why patients refused to have a neuromodulation system implanted, or were very disappointed when they had a system implanted and needed an MRI scan. Another important future are the implantable tibial nerve implants. Although for clinical practice, rechargeable smaller batteries and MRI-safe implants are available, the implantable tibial nerve implants are still under clinical research and are experimental and not clinically available. but I'm sure that in 1 to 2 years, some of these systems will come on the market for clinical application because the clinical research is going well, the results are very promising, and the morbidity of these implants is rather low or non-existent. Having said all that, we are facing new difficulties in our clinical practice, because as more systems become available, more choices become available, different choices become available, and we have to take decisions from an anatomical point of view, and I'm sure in the discussion we can come back to that. We have to make anatomical choices. That means a choice between the sacral nerve or the tibial nerve. We have to make technological decisions, a rechargeable versus a recharge-free battery, a sacral implant or a tibial implant. And for the time being, there are no specific algorithms. So it will be just by clinical guidance and by theoretical concepts that we can be guided in order to make appropriate choices for an individual patient. However, I hope with the pros and cons of the different systems as I present them, that for the time being there is some guidance when in the next future you have to make these decisions. Next slide. So what else? Well, we have still a bit more than 20 minutes available for questions and hopefully answers, but I will end my presentation by hoping that you're all safe, well, and keep healthy for now and for the future. Thanks for your attention, and Kari, I'm ready for your question.
Thank you very much. First of all, do you hear me?
I can hear you very well.
Excellent talk, and I'm as hopefully people who were listening could listen to us. We had some technical difficulties in the middle, but you did a great job, and we are now here. So there are some questions which I will make first from the. So the most recent question is our colleague from Marcio Kerrebroeck from Brazil. Which
okay, hello Marcio.
Marcio, you very well know. He asks, what could guide the clinical choice between the r-SNM system and the InterStim?
Yeah, that is indeed, as I said, is the clinical challenge. And I try to indicate a certain patient profile for each of the systems. I think in slim patients, definitely in the very slim patients, there is definitely a reason to opt for the smaller batteries, so the rechargeable system. In more obese patients, I would be more reluctant to implant a rechargeable system because for the reasons I indicated, and there definitely I would go more for a recharge-free system. Also, if patients from a psychological point of view are less stable, are more volatile, or have some cognitive problems, again, I would feel more comfortable with a recharge-free system than a rechargeable system, because I would be afraid that these patients will phone me every day to ask questions on recharging, on the problem of recharging. They will have problems with recharging and so on. So these are in gross the major guidelines that can help us. And I think with some experience, there is a clear profile for patients that would suit for one system and for another system. Having said that, I think we have to realize that one of the major disadvantages of the recharge-free system, that they had to be replaced every 5 to 7 years, that with a meticulous standardized technique as it has been described, that we can have a minimal necessity for electric current and hence we can prolong the life. So this is one of the major disadvantages of the recharge-free system, that has been solved in that respect. Still, a reoperation every 10 years can be necessary. So that again is something we have to discuss with patients, and definitely patients with major risk for surgery, bleeding disorders, or patients prone to infection would rather be candidates for rechargeable systems than recharge-free systems.
So can you, excellent advice. Can you a little bit continue with that what do you believe and what the evidence says, what determines the longevity of the recharge-free battery, like the battery itself?
Yeah. Yeah, excellent question. And
that was asked on the forum as well.
Well, we have no absolute evidence because, as I said, the company, Axonics in case, indicates, and this has been also accepted by the authorities, that based on simulation studies, the longevity of this battery would be minimum 15 years. Now, I hear quite often when telling this that people say, well, you know, my phone this battery is okay for 15 years. Now we have to realize that with neuromodulation systems, we're working at a low amplitude of stimulation. So that's already one advantage that prolongs battery life. Also, we do not have big jumps in current output, which is another element that fatigues batteries for telephones and so on. And so shelf studies have shown that indeed these batteries have a minimal longevity of 15 years, but probably it even could go up to 25 years. But of course, the final proof will be in clinical practice. But as far as I understood, and also this was convincing for European and American authorities, a guarantee of 15 years longevity should be there.
Okay, so when you think about these two different sacral neuromodulation systems, what do you see as the most common and most important complication and the differences in the complications between them?
Yeah. Well, I think we will see new complications related to the fact that new systems are on the market, because the problems that we see with the recharge-free systems, we know. We have now more than 20 years, up to 25 years of experience. So we went through all the problems and the complications with the actual system. And so I do not think that that will be so different. I think the major factor in preventing the necessary for revision is the optimal implantation technique. So I would stress everybody to read the article that is describing this optimal implantation technique, because that clearly reduces complications, reprogramming, and repositioning of the electrode. One of the problems with a recharge-free system that we sometimes see is pain at the battery due to mechanical hinder or patient is complaining of the volume of the battery. That definitely can be solved with the smaller battery. Having said that, with the smaller batteries, although we can say, okay, small is beautiful, as I indicated, definitely in more obese patients, we probably will see some problems of rotation of the battery. We will see difficulties in finding the battery in some patients. So our clinical experience is still too limited to have a final idea of that. But we know from clinical experience in the Netherlands and also in the UK that patients may have more questions concerning recharging. Sometimes they cannot find the battery, they forget to recharge, they lose the system, and this kind of problems that we do not have with recharge-free systems. So in summary, it's not a black and white picture. There are advantages and disadvantages of each of the systems that I tried to address in the lecture. And therefore, I think that the selection of patients for each of the systems, guided by the elements as I indicated them, is very important. And for the rest, experience will learn if there are other factors that we do not see at the moment yet.
So then there are a couple of new questions on the forum from. Thank you for the nice lecture. What about the TTNS, transcutaneous tibial nerve stimulation? What is your recommendation on using such technique rather than percutaneous route?
Yeah, there is a lot of debate on that, and I recently did a review of the articles that have been published on transcutaneous stimulation, and we get conflicting results in that respect. Globally, we can say that there are some results with transcutaneous tibial nerve stimulation, that if there is a clinical efficacy, seems similar to the clinical efficacy that we see with percutaneous or that we see with implanted tibial nerve stimulation systems. But globally, we can say that the effects are more limited. Also, we have to realize that the studies that I know with transcutaneous in general were studies with smaller groups of patients, so we can discuss the power of these studies, are not sham studies, sham-controlled studies, so there definitely is a huge placebo effect, and also the majority of these studies were short-term studies. Now, in practice, if you have the logistics and the equipment to do transcutaneous stimulation, of course, it's a minimal invasive technique that you can apply, see what is the effect. And what I know from the literature and also from personal experience is that the positive effect on transcutaneous stimulation eventually is a positive predictive factor for other stimulation techniques, in case percutaneous, probably also implanted tibial nerve stimulation, and even eventually sacral nerve stimulation.
Okay. So then there's another little bit different question, which is, would the use of InterStim also serve as a therapy for urinary incontinence or only for the OAB is one question.
Well, clearly the sacral nerve neuromodulation addresses problems of storage problems, I would say, rather than overactive bladder. So any element of storage problem can be solved with neuromodulation. Of course, it's clear that stress urinary incontinence is not an indication for neuromodulation. On the other hand, if there is also a factor of voiding difficulty together with storage problems, that definitely can be addressed with sacral nerve neuromodulation, because, as you know, sacral nerve neuromodulation is also an excellent modality for avoiding difficulties, even up to patients with urinary retention.
In one of your slides, there was about MRI imaging and InterStim. Is MRI really contraindicated with the InterStim II?
Yeah, that is the official documentation as delivered by Medtronic. So the company does not take any responsibility, and many radiologists will refuse to do an MRI scan in a patient implanted with an InterStim II system, with exclusion, as I indicated, for a head scan, of course. Having said that, there are some studies that indicated that also an InterStim II system or the InterStim II lead does not create significant heating at the level of the nerve, and hence is not potentially dangerous, and that when the battery is in a blocked position, the MRI will not damage the battery. And hence we had some patients where indeed we did an MRI scanning with an InterStim II implanted without any damage, but then you have to find a radiologist that is willing to do it, and the patient has to sign an informed consent, so to prevent any liability towards the one doing the MRI. But I think this problem is solved now with the MRI compatible systems. So I think that the InterStim II system very soon will not be available anymore, because clearly it is a limiting factor.
Mm-hmm. Then there's a question regarding ICS BPS patients. if considering implanting in these patients, what are the current criteria regarding suitability? Many of these IC BPS patients have comorbidities, including systemic autoimmune diseases and allergy/intolerance syndromes. Which of these would make a patient too risky for a neuromodulation device implant, in your opinion?
Yeah, indeed, a very important clinical challenge. There has been some good research looking into this with sometimes spectacular results, but overall, I would say only short-term results. With long-term follow-up, we see a very high recurrence rate of the symptoms. So that means that in this type of patients, we have to be even more critical and ask ourselves to which extent we are ready to implant a quite expensive system that eventually will have only effects for a couple of years, and then recurrent symptoms will appear. A lot of research is still ongoing with different modalities of stimulation, for example, high-frequency neuromodulation. So in my clinical practice, PBS or interstitial cystitis with pain in itself was not seen as an indication for neuromodulation. However, we had several patients with lower urinary tract dysfunction and concomitant pain problems that were implanted with good results. And then sometimes also there you can see recurrence of the pain symptoms after initial very positive outcome. Then sometimes you can recuperate pain control with high-frequency stimulation up to 80 Hertz, which we know now is safe and feasible.
So then there's a question for Cecilia Hernandez. What is the most effective type of neuromodulation? Why are the same stimulation parameters used for overactive bladder and urinary retention? And are there new devices for pudendal nerve stimulation?
Yeah. I will address the easiest part, which is the stimulation parameters. Why the same stimulation parameters for storage symptoms and avoiding systems? Well, this relates to the working mechanisms of neuromodulation. And of course, this is quite complex, but in simple words, in fact, we can say that at the level of the midbrain, the paraventricular gray, there are two centers controlling the function of the lower urinary tract. There is a stimulation center and an inhibition center. Any functional form of lower urinary tract dysfunction is the result of a disbalance between these two. The electric current put in the body will rebalance these two centers and will restore that balance and hence lower urinary tract function. So that's the reason why same stimulation parameters can address the storage problems and the voiding problems, and also why storage and voiding problems, when they are concomitant, can be addressed. A more difficult part of the question is which anatomical localization addresses best the problems. Is this the sacral nerve? Is this the tibial nerve? Is this the pudendal nerve? The difference between sacral and pudendal has been researched quite well, especially by Ken Peters in the US, where he implanted patients that were a failure with sacral nerve stimulation with pudendal nerve stimulation and could recuperate some of these patients with pudendal stimulation. We could conclude from that pudendal is better than sacral. It's a thicker nerve with different nerve fibers. On the other hand, the pudendal nerve is, from an anatomical perspective, much more difficult to approach, to reach. The fixation of an electrode in that neighborhood is also more difficult. So I think for wider clinical application, pudendal nerve stimulation is more or less a recovery form of neuromodulation. A more difficult topic is the difference between tibial and sacral nerve. There is not a lot of research making a straightforward comparison between the two techniques. And in fact, we could say that a positive outcome of tibial nerve stimulation is a predictive factor for sacral nerve neuromodulation. On the other hand, we see some patients that do not do well with tibial nerve stimulation and also do not well with sacral nerve stimulation. So there are primary failures for one reason or another, which is unclear, and perhaps future PET scanning will give indications that we do reach different centers or not the good centers. The PET scanning studies that have been performed make a comparison between sacral and tibial nerve indicate that these techniques address indeed different areas in the brain. So there definitely are differences in centers in the brain that are activated. A remarkable fact is that it seems that tibial nerve stimulation is not doing well for patients with urinary retention, definitely not as good as sacral nerve neuromodulation. So the question remains open. I think the major drawback of tibial nerve was the fact that there was not yet a permanent implant. So I think when these implants are accepted, this creates a big future, a great future for tibial stimulation. It could be the first choice, and only if that fails, then the second choice could be sacral nerve. But that's still a topic for a future lecture, perhaps next year when we have more implants available.
Good, thanks. Then there's a next question from Paula. Mikolai Project asks, what is the effectiveness of sacral neuromodulation in detrusor or hyperactivity with impaired contractility, DHIC?
Yeah, that's indeed, again, an important group. The problem is that very few studies looked specifically at that group of patients. So we only can look at a subset of populations that have been studied in clinical application of neuromodulation. Clearly, we have to discriminate different degrees of the detrusor contractility impairment. We know that up to a certain degree, and therefore we were working in Maastricht with a nomogram to predict this effect, that in certain patients with still a certain degree of contractility preserved, neuromodulation can work very well. When there is absolute no contractility anymore, forget that neuromodulation will make the detrusor contract again. So in that combination with overactivity and underactivity, definitely it's worth trying to do the neuromodulation. But in these patients, I would advise to do a urodynamic control to see what is the effect of the neuromodulation. It's one of the very few indications in the screening for the effect of neuromodulation for urodynamics.
So very last question and a very quick answer, Philip. The last question is, percutaneous tibial nerve stimulation recommended for voiding symptoms and retention or only for storage symptoms? As I said before,
so far as we know, the effects of tibial nerve stimulation in voiding difficulty or retention are not as good, only temporary and probably more linked to placebo effect than to really efficacy. And we also know from the colorectal surgeons that also for fecal problems, tibial nerve stimulation definitely is not as good as sacral nerve stimulation. So I think for the time being, till we find new treatment modality, new stimulation parameters, I think that for retention patients or patients with severe voiding dysfunction, tibial nerve stimulation is not the way forward, and these patients should be addressed with sacral nerve stimulation for neuromodulation.
Very valuable comments and questions. I actually have personally still one for the little bit more junior and less experienced. So when somebody is listening to this and they are not performing any, can you quickly say some hints which may be difficult, how to, from this bazaar of options, how would you begin and where would you, because there's now many options, is there any quick advice how to begin and with the different approaches?
Quick, because definitely experience is needed. So I would advise to go to an experience center or follow one of the courses and really be instructed. I know that, for example, Medtronic is organizing these courses, definitely in Europe, and I think also in the US and other parts of the world. So there more detailed information is given, because the key of success indeed is careful and appropriate selection of patients. And in view of the new treatment modalities, this is even more the case.
Exactly, and that kind of grants can also younger generation get from the ICS.
Exactly.
So and to visit and learn from the experts and then maybe bring it to your own center. Thank you, Philip, very much for your talk today.
My pleasure.
And sorry for a little bit technical problems. Hopefully people will allow to follow us. Stay safe during the Corona time and after, and look at the ics.org/live. There's other upcoming live events and which they are being put on by the ICS during this lockdown period.
Hope to see the people in the ICS meeting in Las Vegas, hopefully.
Yeah, and this lecture is also going to be on YouTube. So have a great weekend and thank you, everyone.